Welcome to today's presentation on dementia, Alzheimer's disease, and patient care. In this presentation, we will define what dementia is, we will recognize the major forms of dementia, especially the most common type, Alzheimer's disease, and explore various concepts of patient care aspects. This presentation is being presented today by Celtic Healthcare Staff Development Department. The objectives for this in-service is to be able to define dementia and recognize major forms, identify the various stages of dementia, recognize common signs and symptoms of dementia, state 4 interventions that may be used when working with dementia patients, identify that aphasia patients have difficulty using or understanding language, and being able to state 3 interventions that may be used when working with aphasia patients. So what is dementia? Dementia is a term for loss of memory and other mental abilities severe enough to interfere with daily life. It is caused by physical changes in the brain. Dementia is a group of symptoms caused by gradual death of brain cells. The loss of cognitive abilities that occurs with dementia leads to impairments in memory, reasoning, planning, and behavior. While the overwhelming number of people with dementia are elderly, dementia is not an inevitable part of aging. Instead, dementia is caused by specific brain diseases. The prevalence of dementia is difficult to determine, partly because of differences in definition among different studies and partly because there is some normal decline in functional ability with age. The prevalence of dementia roughly doubles for every 5 years of age beginning at age 60. Dementia affects about 1% of people between ages 60 to 64. 5 to 8% of all people between 65 and 74, up to 20% of those between 75 and 84, and between 30 to 50% of those age 85 and older. About 60% of nursing home patients have dementia. The Alzheimer's Association estimates that in 2007, 5.1 million Americans were living with a diagnosis of dementia. That number expected to grow substantially as the population ages. The cost of dementia can be considerable. While most people with dementia are retired and are not affected by income losses from their disease, the cost of care is often enormous. Financial burdens include lost wages for family caregivers, medical supplies and drugs, and home modifications to ensure safety. Nursing home care may cost several $1,000s a month or more. The psychological cost is not as easily quantifiable, but can be even more profound. The person with dementia loses control of many of the essential features of his life and personality, and loved ones lose a family member even as they continue to cope with the burdens of increasing dependence and unpredictability. So dementia is basically a dysfunction or disease of the brain. A wide array of impaired symptoms include judgment, thought, memory, reasoning, understanding, learning, and knowledge. Dementia has been recognized since ancient times as a consequence of aging. Today is a major public health concern. Approximately 5.2 million people in the United States have Alzheimer's disease at all ages. 1 in 9 individuals, 65 and older, or 11%, have Alzheimer's disease. If we do not discover a cure, over 14 million people will be affected with this disease in 2030. Dementia can occur at any age and is not a normal sign of aging. Normal may be an occasional memory loss or what have you, but dementia is not normal. Changes occur in people are attitudes, personality, performance, and behavior. Dementia is usually caused by degeneration in the cerebral cortex, the part of the brain responsible for thoughts, memories, actions, and personality. Death of brain cells in this region leads to the cognitive impairment that characterizes dementia. The most common cause of dementia is Alzheimer's disease, accounting for 1/2 to 3/4 of all cases. Other conditions that cause dementia include brain tumors, infections, trauma, nutritional disorders, and toxic effects of chemicals and drugs. Let's explore the costs of dementia. Dementia costs this country $157 to $215 billion annually, making the disease more costly than either heart disease or cancer. The greatest economic cost is providing institutional and home-based long-term care rather than medical services. If age-specific prevalence rates remain constant with the growth of the aging population, this cost will double by 2040. In 2010, 14.9 million family members and friends provided 17 billion hours of unpaid care to those people with dementia. Economic value of unpaid care was $202.6 billion in 2010. More than 60% of caregivers rate the emotional stress of caregiving as high or very high, and over 30% report symptoms of depression. The physical and emotional impact of caregiving is estimated to result in $7.9 billion in increased health costs. The golden rule with dementia patients is that they cannot change or control their behaviors. Dementia patients are not responsible for their actions. Dementia is very similar to having a disability. Do not take dementia patients' actions and comments personally. They do not mean what they say or do. Do not respond with anger or frustration. That will only upset them more, agitate them, and cause increased anxiety. Now let's take a look at the major forms of dementia. The most important or common one is Alzheimer's disease. You'll also have multi-infarct or vascular dementia. There's also dementia with Lewy bodies, dementia with Parkinson's disease, frontotemporal dementia, and Creutzfeldt-Jakob disease. Also, some other forms of dementia are normal partial hydrocephalus, Huntington's disease, Wernicke-Korsakoff syndrome, HIV-associated dementia or age dementia complex, neurosyphilis, and traumatic brain injury. Alzheimer's disease was first identified and named in 1906 by Dr. Alois Alzheimer, a German neuropathologist. This is the most common form of dementia and accounts for 60 to 80% of all dementias. The brain of a person with Alzheimer's disease becomes clogged with two abnormal structures called neurofibrillary tangles and senile plaques. The neurofibrillary tangles are twisted masses of protein fibers inside nerve cells called neurons. Senile plaques are composed of parts of neurons surrounding a group of proteins called beta amyloid deposits. Why these structures develop is unknown. Current research indicates possible roles for inflammation, blood flow restriction, and molecular fragments known as free radicals. Several genes have been associated with higher incidence of Alzheimer's disease, although the exact role of these genes is still unclear. The onset for Alzheimer's disease is between 65 and 80 years of age and may progress over 5 to 20 years. As many as 5 million Americans are living with this disease that destroys brain cells, causing problems with memory, thinking, behavior, severe enough to affect work, lifelong hobbies, or social life. It's now the 7th leading cause of death in the United States. There are multiple stages of Alzheimer's disease that we'll discuss later on in this presentation. Multi-infarct or vascular dementia is the second most common type of dementia. Vascular dementia is estimated to cause 5 to 30% of all dementias. It occurs from the decrease in blood flow to the brain, most commonly due to a series of small strokes, multi-infarct dementia. Other cerebrovascular causes include vasculitis from syphilis, Lyme disease, or systematic lupus, subdural hematoma, and subarachnoid hemorrhage. Because of the sudden nature of its cause, the symptoms of vascular dementia tend to begin more abruptly than those of Alzheimer's dementia. Symptoms may progress stepwise with the occurrence of new strokes. Unlike Alzheimer's disease, the incidence of vascular dementia is lower after age 75. So some features, again, occurs when there is a reduced blood flow to parts of the brain and it starves the cells of food and oxygen. may be due to cardiac and diabetic disease, and the onset is usually between 60 to 75 years of age. Another form of dementia is Parkinson's disease. Parkinson's disease affects control of movement, resulting in tremors, stiffness, and impaired speech. Many individuals with Parkinson's also develop dementia in later stages of the disease. Drugs for Parkinson's can help steadiness and muscle control, but have no effect on dementia symptoms. Dementia with Lewy bodies is another type of dementia. This dementia often starts with wide variations in attention and alertness. Individuals often experience visual hallucinations, as well as muscular rigidity and tremors similar to those associated with Parkinson's disease. Frontotemporal dementia, or Pick's disease, is another common form of dementia. This is a rare disorder that may be hard to distinguish from Alzheimer's disease. It is characterized by personality changes and disorientation that often occur before memory loss. Normal pressure hydrocephalus, or NPH, is another form of dementia. This is caused by a buildup of fluid on the brain. The cause of most cases is unknown. Symptoms of normal pressure hydrocephalus include difficulty walking, memory loss, and inability to control urine. NPH can sometimes be corrected with surgery to drain the excess fluid from the brain. Creutzfeldt-Jakob disease, or CJD, is a rare, rapidly fatal disorder that impairs memory and coordination and causes behavioral changes. Recently, variant Creutzfeldt-Jakob disease, or VCJD, was identified as the human disorder believed to be caused by eating meat from cattle affected from mad cow disease. Huntington's disease is another form of dementia. This disease is an inherited, progressive disorder that causes irregular movements of the arms, legs, and facial muscles, personality changes, and a decline in the ability to think clearly. Traumatic brain injury can cause another form of dementia. Traumatic brain injury is caused by significant trauma that can damage or destroy brain cells and cause symptoms of dementia such as behavioral changes, memory loss, and other cognitive difficulties. There is no single test that will diagnose dementia. In order to diagnose, one's doctor must rule out other possible causes of symptoms, such as forgetfulness. A complete evaluation helps determine whether dementia is the cause of person's symptoms. Diagnosis begins with a thorough physical exam and complete medical history, usually including supplemental information from family caregivers. A family history of Alzheimer's disease or cerebrovascular disease may provide clues to the cause of symptoms. Simple tests of mental function, including word recall, object naming, and number-symbol matching, are used to track changes in the person's cognitive ability. Depression is common in the elderly and can be mistaken for dementia. Therefore, ruling out depression is part of the diagnosis. Distinguishing dementia from the mild normal cognitive decline of advanced age also is critical. The medical history should include a complete listing of drugs and dosages being taken, since a number of drugs can cause dementia-like symptoms in the elderly. Determining the cause of dementia may require a variety of medical tests chosen to match the most likely etiology. Cerebral vascular disease, hydrocephalus, and tumors may be diagnosed with X-rays, CT or MRI scans, and vascular imaging studies. Blood tests may reveal nutritional deficiencies or hormone imbalances. There are 10 warning signs of Alzheimer's disease. The first one being memory loss. This is memory loss such as forgetting recently learned information, and is one of the most common early signs of dementia. Normal memory loss is forgetting names or appointments occasionally. The second warning sign is difficulty performing familiar tasks, such as finding it hard to plan or complete everyday tasks. One may lose track of steps involved in preparing a meal, placing a telephone call, or playing a game. What is normal? Normal part of aging is occasionally forgetting why you came into a room or what one planned to say. Anything past that might be a warning sign of Alzheimer's. The third warning sign is problems with language, forgetting simple words or substitute unusual words, making speech or writing hard to understand. They may be unable to find a hairbrush and instead ask for that thing for my head. What is normal? Sometimes having trouble finding the right word. The fourth warning sign is disorientation to time and place. One can become lost in their own neighborhood, forget where they are and how they got there, and not know how to get back home. Normal for aging is forgetting the day of the week or where you might be going. The fifth warning sign is poor or decreased judgment. Dressing inappropriately, wearing several layers on a warm day, or little clothing in the cold. One may show poor judgments about money, like giving away large sums. Normal in aging is making a questionable or debatable decision from time to time. The sixth warning sign is problems with abstract thinking, forgetting what numbers are and how they should be used. Normal for aging includes finding it challenging to balance a checkbook. The seventh warning sign is misplacing things. One may put things in unusual places, an iron in the freezer or a watch in the sugar bowl. What is normal for aging? Misplacing keys or wallet temporarily. The eighth warning sign of Alzheimer's is changes in mood or behavior. Rapid swings from laughter to tears to anger for no apparent reason. Normal for aging is occasionally feeling sad or moody. The ninth sign of Alzheimer's is changes in personality. Dramatic. They may become extremely confused, suspicious, fearful, or dependent on family members. What is normal? Well, people's personalities do change somewhat with age, but anything drastic is a possible warning sign. And the 10th warning sign is loss of initiative. One may become very passive, sitting in front of the TV for hours, sleeping more than usual, or not wanting to do usual activities. What is normal? Sometimes feeling weary of work or social obligations. There are several possible exhibited symptoms with dementia. First one being memory impairment. It interferes with the ability to learn new things. It interferes with the ability to remember what you've learned and retrieve stored information. Short-term memory is usually the first one affected, and then long-term memory at later stages. Another possible symptom of a dementia includes frightened or confused behavior. Encourage the patient to confide in his fears. Show acceptance, patience, and compassion with those patients. Make the patient feel safe. And use nonverbal communication to reinforce words, such as touching a hand or putting a hand on a shoulder. Asking repetitive questions is another possible symptom. If the patient repeats their questions, answer the question again, being supportive to the patient. Do not sound curt, frustrated, or irritated, or you will cause the patient to become anxious and agitated. Because of the memory issues, disorientation is another possible symptom exhibited with dementia. Making sure you have the patient in a familiar area, or place objects within sight that the patient may know. Try to distract the patient if they get upset with being disoriented. Reality orientation is another issue with dementia. People become confused with what's reality and what's not. So try to reduce confusion and withdrawal. Encourage patient to think. Repeat some information intermittently about person, place, and time. Reorientation to person. Try to call the patient by name as much as possible. Use names when referring to others, and wear your name tag so that person knows you and knows your name and who you are. Some issues with reality orientation is orientation to place. Making sure you're labeling objects, keeping objects that are requested frequently where patient can see them and know where they are at. Also, reorientation to time. Put a clock where a patient can see it. Cross off days on a calendar. Follow a daily routine. Very important for those dementia patients. Another symptom of dementia could be an inability to carry on a conversation. Patient may have slurred or slow speech or wrong word choice. And you want to use these strategies to assist the patient. Correct sensory deficits. So have them wear glasses and their hearing aids so they can hear and see you. Include patient in the conversation. Just because you think they may not understand or may not hear does not mean that they can't be included. Stand where your patient can see you when you're talking. Use short, simple, familiar words. Speak slowly and clearly. Allow enough time for response. Substitute correct word for patient if patient doesn't get angry. And continue to talk to the patient even if little response returned. And aphasia correlates to inability to communicate. Aphasia is the loss or decreased ability to use or understand language due to the brain disease or damage. Patterns of speech may be interrupted. The brain cannot receive, process, and express thoughts, ideas, or information properly. Some causes of aphasia are trauma, infections, toxins, tumor, or cerebral vascular accident or stroke. A lot of these causes are the same causes for dementia, so there's a correlation there. There are 3 types of aphasia. The first type is expressive. The patient can understand what others are saying, but cannot put own thoughts into words. There's also receptive aphasia. The patient cannot understand what others are saying. There's some kind of mental impairment, confusion, and memory loss. And there's the global aphasia. There's severe brain damage. There's little or no intake or output from the patient. They cannot understand what you're saying, nor can they correlate and put thoughts into their own words. So they may say things or count over and over again with global aphasia. Some concepts of patient care with the patient with aphasia, regardless of if they have dementia or not. Offer encouragement. Include the patient in conversation. Speak slowly, clearly, naturally, and in normal volume. Repeat or rephrase to confirm understanding. Ask yes/no questions. Allow time for patient to respond and do not interrupt. Don't correct mistakes unless instructed by the speech therapist. Use nonverbal cues, such as point to the water glass. And keep the atmosphere light and non-stressful for the patient. Some common communication problems with aphasia: the loss of ability to name things, difficulty in producing sounds, substituting words for the same category, difficulty understanding multi-step commands, speaks occasionally with keywords only, rambling on in nonsense sentences, and changes in communication vary throughout the day. Some caregiver/family considerations for aphasia: fears and frustrations related to communication barriers. The family may be frustrated that their family member cannot understand. They're fearful that patient or family member may not understand them. Because of that, they may treat the patient like the child, or they may anticipate their needs and speak for the patient when that's not truly how the patient is feeling. Some intellectual changes with dementia. Patients have difficulty with making decisions, keeping their train of thought, following simple directions. Some interventions that you could take because of this are promote the most independence of the patient, show interest, enthusiasm, and praise modest accomplishments. Also, you can encourage the patient to perform simple, safe, and doable tasks which are within their limits of their ability. Don't expect perfection. Repeat the same questions or information. Reinforce with actions and explain, demonstrate in clear, simple, step-by-step directions. You'll often see some personality and behavior changes with patients with dementia. You'll see wandering, walking around without any purpose. Delusions. They believe something to be true that is actually false. May have hallucinations. They actually see, hear, or experience something that is not there. Or mood swings. Anger or agitation are the most common. The most common form of dementia, which is Alzheimer's disease. There are 4 main stages of Alzheimer's disease. There's the early stage, middle, late, and terminal. In the next several slides, we're going to discuss the differences between each stage. Stage 1 of Alzheimer's is the early stage. The clinical display you'll most often see is memory loss. Maybe occasional memory loss at first. And then also many patients may also exhibit signs of depression. This stage may last as long as 2 years, with memory lapses, loss of spontaneity, intermittent loss of words, easy to anger, and difficulty with making choices. Stage 2, or the middle stage of Alzheimer's disease, you'll see all the signs from the early stages worsen. The memory loss affects day-to-day living. You'll see more cueing and prompting needed to complete ADLs, and you'll have decreased ability to cope in unfamiliar surroundings. The middle stages of Alzheimer's disease last from anywhere from 2 to 5 years and may include disoriented to time and place, impaired communication, trouble with making decisions and plans, loss of impulse control, mistakes in judgment, wandering and placing, decreased concentration, increased self-centeredness, try to avoid new situations, delusions, and rummaging, hoarding, and raiding. Stage 3, or the late stages of Alzheimer's disease, exhibited signs from both early and middle stages continue. Short-term memory no longer exists, and long-term memory begins to fail. Communication is extremely limited. Motor skills are impaired, and assistance is needed for the simplest tasks, such as walking. The late stage of Alzheimer's disease can last anywhere from 2 to 5 years. You'll see confusion after the sun goes down, or sundowning syndrome, disorganized behavior in threatening situations, objects placed in the mouth often, uncontrollable repeating an activity, unable to recognize objects, and unable to do activities or movements that they normally were able to complete. And finally, stage 4, or the terminal stage of Alzheimer's disease. This can last anywhere from 5 to 10 years. You'll see limited or lack of communication, total dependence in ADLs and IADLs, unable to recognize self or others, and eventually the disease overpowers the patient and death occurs. Now we're going to take a look at components of care for dementia patients. Care of a person with dementia can be difficult and complex, and currently there is no cure and no way to stop the underlying death of brain cells. But drugs and non-drug treatments may help with both cognitive and behavioral symptoms. Like I stated on the last slide, care for a person with dementia can be difficult and complex. The individual with dementia must cope with functional and cognitive limitations, while family members or other caregivers assume increasing responsibility for the person's physical needs. In progressive dementia such as Alzheimer's disease, the person may ultimately become completely dependent. Education of the patient and family early in the disease progression can help them anticipate and plan for inevitable changes. Behavioral approaches may be used to reduce the frequency or severity of problem behaviors, such as aggression or socially inappropriate conduct. Problem behavior may be a reaction to frustration or overstimulation. Understanding and modifying the situations that trigger it can be effective. Strategies may include breaking down complex tasks, such as dressing or feeding, into simpler steps, or reducing the amount of activity in the environment to avoid confusion and agitation. Pleasurable activities such as crafts, games, and music can provide therapeutic stimulation and improve mood. Modifying the environment can increase safety and comfort while decreasing agitation. Home modifications for safety include removal or lockup of hazards such as sharp knives, dangerous chemicals, and tools. Child-proof latches or Dutch doors may be used to limit access as well. Lowering the hot water temperature to 100 degrees Fahrenheit or less reduces the risk of scalding. Bed rails and bathroom safety rails can be important safety measures as well. Confusion may be reduced with simpler decorative schemes and presence of familiar objects. Covering or disguising doors with a mural, for example, may reduce the tendency to wander. Positioning the bed in view of the bathroom can decrease incontinence. Long-term institutional care may be needed for the person with dementia, as profound cognitive losses often precede death by a number of years. Early planning for the financial burden of nursing home care is critical. Useful information about financial planning for long-term care is available through Alzheimer's Association. Family members or others caring for a person with dementia often are subject to extreme stress and may develop feelings of anger, resentment, guilt, and hopelessness. In addition to the sorrow they feel for their loved ones and for themselves, depression is an extremely common consequence of being a full-time caregiver for a person with dementia. Support groups can be an important way to deal with the stress of caregiving. The location and contact numbers of caregiver support groups are available from the Alzheimer's Association. They may be also available through a local social service agency or the patient's physician. Medical treatments for depression may be an important adjunct to group support. One of the key components of care for dementia patients is restorative and rehabilitative care. We want to maintain a sense of dignity and self-worth for the patient. We also maintain functional levels in ADLs and prevent complications. Rehab care can provide assistance when needed, but encourage residents to help with care whenever possible.
Some support measures that can become part of the patient's care is to help reduce agitation and anxiety, prevent threatening situations for the resident, and keep dignity and quality of life important. Remember the identity of the person, respect their privacy, pay attention to their appearance, and treat the person as an adult.
One of the key components of care for dementia patients is preventing complications. One of the main issues with patients with dementia is wandering. As Alzheimer's progresses, wandering and restlessness are very common. Please ensure that the patient can be returned home safely. Put labels in their clothes with their name and contact information. Another option is getting a medic alert bracelet to help stop the wandering. Ask the doctor if light exercise may help them sleep. Consider putting locks on all windows and outside doors, but make a plan for fire safety first. Install a keyed deadbolt or a new lock up high or down low on the door. Place bells on the doors to awake you or the caregiver if the patient tries to leave, and place locks at the bottom of the door since the patient may not look for them there. Other complications can include inability to recognize signs of danger. They also have impaired decision making, so we want to prevent complications of that. Their impulsivity, memory problems, alter nutrition because of short attention span and not remembering that they are there to eat, inability to recognize objects that may cause them harm, and inability to do activities or movement which may then lead to bed sores or other issues.
Another possible complication is inadequate nutrition and aspiration. Some ways to prevent against impaired nutrition is you may have the patient use special eating utensils, provide nutritious finger foods, add thickeners to liquids if resident is at risk for choking or aspiration, use liquid supplements such as Ensure or Boost, change to a pureed or chopped foods when needed, or possibly feed the resident. Some ways to reduce the risk for aspiration is allow the resident to rest before eating, sit resident up at a 60 to 90 degree angle before, during, and for 1 hour after eating, Keep the resident's head in line with his or her neck slightly bent when swallowing, and reduce distractions when eating. Another potential complication is pressure ulcers due to impaired mobility and incontinence. Some ways to help prevent impaired mobility is to provide help for transfers and walking, use lift devices if needed, use equipment to keep body alignment and stop pressure, such as air mattresses or cushions for wheelchairs, reposition the resident frequently, provide passive range of motion exercises, and educate on fall prevention. Some ways to reduce the risk for pressure ulcers: schedule regular trips to the bathroom to decrease incontinence, use incontinence briefs or diapers, apply skin barriers, check the skin regularly for breakdown, reposition the resident on an every 2-hour schedule, maintain good nutritional status, and then move the resident gently to avoid skin tears and bruising. Another important aspect of the care of dementia patient is managing other illnesses. They may have a change in appetite, increase in confusion, a change in their sleep pattern, falling by someone who is normally a steady walker, change in urine or bowel patterns, or may have a temperature elevation. Some other illnesses that may occur in the dementia patients: having an increase in restlessness, agitation and anxiety. And some ways to help with those sensory or perceptual changes is provide some stimulation for a resident without overstimulating, use of recliner chair to bring person out of their room and to be included in activities, play soothing music, give hand massages, and talk quietly. You may also have the constipation, pneumonia, and frequent urinary tract infections. Some general management techniques for the care of dementia patients are: keep consistency with staff and routines, break tasks into small tasks, provide cues for the patient, limit distractions when they're trying to complete a task, use good communication skills, encourage good diet and fluids, reward positive behaviors, and support family and friends. There are many family concerns with these type of patients. We want to educate and encourage the family to continue to interact with these people. Avoid isolation for the resident. Be flexible. Encourage laughter. Recommend support groups for families. And there's also a lot of suggested community resources that could be offered by social workers or even by the Alzheimer's Association, www.alz.org.
So what can caregivers and families do to help? First of all, they can make allowances. Remember, they are not acting this way on purpose. Don't take any action personally. It's the disease talking. The caregiver or family can show interest, maintain eye contact, and stay nearby so they will know you're listening and trying to understand them. Avoid distractions and noise. Communication is difficult against a background of competing sights and sounds. Keep things simple. Use short sentences and plain words. Avoid complicated questions or directions. When communicating a task or request, break it down into single steps. Following a multi-step command will set up for failure. What else can caregivers and family do to help? First of all, don't interrupt. It may take several minutes for them to respond. Avoid criticizing, hurrying, correcting, and arguing with the patient. Use props and visual cues to increase recognition. For example, take the person to where the toilet is visible and point to it before asking if they need to go to the bathroom. Don't argue with the patient. With this disease, reasoning and judgment capabilities decline over time. Avoid trying to convince them that they are wrong and you are right, in which case the most likely outcome will be increased anger and agitation. Also, remain calm and relaxed. Even if you get frustrated, try to keep your voice calm and relaxed. If your words and the way you say them don't match, it may be confusing. Your nonverbal cues, including the tone of your voice, often send a clearer message than what you actually say. And lastly, avoid open-ended questions. Instead, ask yes or no questions. The simpler, the better.
There is hope for the future with these patients with dementia. Continued research into the causes of dementia will provide some necessary information about the prevention and treatment of this relentless disease. Here are some of the resources that were used for this presentation. Also resources that can be utilized for support or more information for care of the patient and for family members, support of the family members.
Thank you for attending today's presentation on dementia, Alzheimer's, and patient care. If you have any questions, please contact your supervisor or any staff member. Now take some time to complete the post-test to complete this assignment. Thanks again for listening. Have a great day.